Hello to everybody. So I'm very pleased to welcome you to this lunch event today around innovation, equity, and the new health economy. It's really also around UHC. My name is Michaela Dold. I'm the Deputy Director. So it's really my pleasure on the behalf of the Global Health Center to welcome you here and wish you also a really engaging discussion on UHC and the new health economy. And really, why we have chosen that word is also that we do have a little project here which has been running for the past few years around the new health economy. We actually moved also beyond, in a sense, bringing in not just the health sector in, but bringing other sectors into the discussion. And that's really also what UHC is about. And we have, of course, this momentum on UHC also now at this WHA very strongly. So I think it is a really timely discussion. It's a good continuation from what we have been doing with our project. We will also make available actually some of our annotated bibliographies, which we have produced as part of the project. And we do hope also to launch a book down the road, and you will hear more about that. And with that, actually, also, I will hand over to Jeff, who will moderate this session. So I'm very pleased. Thank you very much, Jeff, for coming. Thank you also for Rabin Martin for all the support on this, but also John Hopkins, with whom we are working in this project. So, Jeff, the floor is yours.
Thank you. Well, good afternoon, everyone. It's a pleasure to welcome you, and thanks for taking time from a busy week with dozens of events going on at the same time to join us here for a discussion on universal health coverage, and in particular, the role of innovation equity in the new health economy in helping countries to achieve universal health coverage. As Michaela told you, I'm Jeff Sturchio. I'm the CEO of Rabin Martin, a global health strategy consulting firm. I'm also a visiting scholar at the Institute for Applied Economics, Global Health, and the Study of Business Enterprise at the Johns Hopkins University, which is one of the partners in this work, in this project on universal health coverage that we'll be talking about. Now, I just wanted to first start by saying there's a slight change in the program because Professor Ilona Kickbush has been called over to the Palais for a meeting of some importance, which she couldn't decline. So she'll be joining us a little bit later to join the panel discussion. So we'll start with some opening remarks from me, and I'll get to those in a moment. And I've asked Christian Franz, who's the co-author of the chapter in the book that he and Ilona have done on the new health economy, to join the panel to talk about that. So I'll introduce the panelists in just a moment. But let me provide some context for our discussion today. In September 2015, the 70th UN General Assembly adopted the Sustainable Development Goals, which provide a framework for promoting greater equity and prosperity around the world. It was a remarkable achievement, which entailed 190 member states agreeing to a set of 17 goals and 169 targets. So it was a hard-won achievement. And health for all is the objective of Goal 3, a vision first articulated at Alma-Ata 40 years ago. For many in the global health community, the inclusion of universal health coverage as target 3.8 in the health goal was particularly significant. Indeed, some would argue that UHC is at the heart of the SDGs, for it's the only way to ensure greater health equity and quality in all countries around the world, and as the slogan goes, to leave no one behind. Indeed, Dr. Tedros, when he became Director General of the World Health Organization a year ago, declared that all roads lead to UHC, and that that's the top priority at WHO, which has continued to be so for the last year. So it's a very timely discussion to think about how can we work together to achieve universal health coverage. Today, half the world's population is estimated to lack access to basic health services. That's an estimate of about 3.5 to 4 billion people. And this number masks inequities that continue to exist from country to country, gaps between rich and poor, between men and women, young and old, and among people of different ethnic backgrounds. UHC promises to give people greater access to higher quality health services without the fear of financial hardship, but the task of turning this vision into a reality poses a significant challenge for countries, rich and poor alike. Each country will chart its own course to UHC, deciding which health services to cover, who will be covered, how to pay for those services, and how to ensure effective and efficient delivery. Already, more than 100 countries have begun to chart efforts toward that goal, some with more success than others. Some will need help. And as we know, many of the countries still striving to achieve modern economic development will not be able to achieve universal health coverage alone. Weak health infrastructures, a lack of trained health workers, inadequate financing, fragile economies, along with high burdens of infectious disease and chronic illnesses, will continue to pose challenges, particularly in lower and middle income countries. If we look at the experience of countries that have achieved some measure of universal health coverage, we can see several important lessons about successful implementation. Top to bottom political commitment is needed. It's necessary, but it's not sufficient, as we'll see. Adequate sources of health systems financing must be acquired and secured. The institutional capacity to expand services should be strengthened. And the non-governmental sector, both civil society and the private sector, have to be engaged in planning and delivering on the promise of universal health coverage. Now, those are the themes that we're going to be addressing in the book that Michaela talked about. We're hoping that Johns Hopkins University Press will be bringing it out later this year. But we look at universal health coverage in this book after sort of tracing its origins from Bismarck's Germany in the 1880s with social health insurance through the vision of health for all at Alma Ata in 1978 to its incorporation in the Sustainable Development Goals. But beyond that, we look at this through the lens of the private sector and the health economy. While the goal of universal health coverage is elusive in many countries, there are plenty of examples of success to emulate, and the successes encourage us to look at the global health economy from a fresh perspective that stresses the positive aspects of developments that satisfy important demands for health by providing new goods and services. The health sector is highly innovative, has made good use of digital modes of communication, of ways of storing information, and all other things being equal, economies that provide strong health care bolster their human capital and are more successful over the long term. And so in an age in which the importance of human capital has at last become recognized, the role of the health economy is of vital importance. And of course, the emerging health systems also provide a remarkable array of jobs for people. You'll be hearing more about that in the panel discussion. And this includes important work for women in a sector that's distinctly labor intensive. So those are some of the broad perspectives that inform the discussion that we'll be starting in just a minute. And what we want to look at today, and we'll certainly have an opportunity for you to contribute to the discussion, are what are the political and practical implications of moving from aspiration to implementation in universal health coverage, and what are the ways in which the private sector and the health economy are helping and will be helping countries to achieve universal health coverage. What range of capabilities do private companies bring to the challenge of expanding delivery of essential health services? And what opportunities are there as governments, civil society, and companies work together to achieve the goal of universal health coverage? So those are some of the questions that we'd like to address. Let me just ask the panelists to join me up here on the stage. And as they come up, I'll just say a couple of words to introduce them. You have a booklet that has their biographies, so I won't say much. You can read more in the booklet. But the speakers will include, and please come on up and we'll get started. As I said, Dr. Ilona Kickbush is the director of the Global Health Center, will be joining us in a bit. Christian Franz, who's sitting here to my immediate left, is the CEO of CPC Analytics in Berlin. It's a consulting firm that does work in health economics and related topics. Christian's been working with us on this project. Next to him is Cicely Thomas, who's the program director for Results for Development, who has also contributed together with her co-authors a chapter to the book, and you'll be hearing more from her. Next to Cicely is Jim Campbell, who's the director of the Health Workforce Department at the World Health Organization. And next to Jim is Felicia Knoll, who's at the University of Miami Miller School of Medicine and also the Institute for Advanced Study at the University of Miami. So let me join them and we'll start the discussion. The plan is that we will leave at least half an hour for discussion where you can comment and ask questions. So we'll get to that in just a little bit. No, that's all right. I'll just go down here. Thank you. No, it's okay. So, as I said, we're interested in looking at the concept of a health economy because, of course, universal health coverage is going to require not only contributions from the health sector, but also in order to achieve the level of financing that's going to be required, we'll have to gain support from economic and fiscal policymakers as well. And so we can think of the concept of a health economy that encompasses both the resources needed to deliver healthcare services, but also the health services and products that are provided, and the effects that that will have on the economy broadly and also on the health sector itself. So to explicate those ideas, I just asked Christian to tell us a little bit about this concept and how he and Ilona have been thinking about it.
All right. I guess this is on. Thanks everybody for being here. I'm happy to replace Ilona Kickbush for a second. And so thanks, Jeff, for this short introduction on what our work is about, because the overall book gives both a broad view and case studies as well as detailed information and learnings from the field. So Ilona Kickbush and I tried to connect to an ongoing discussion on UHC and in general how health contributes to economic welfare and vice versa. And what we have seen is that the political case is made in a way, right? Jeff said it, UHC is part of the SDGs, there are strong coalitions, both within international organizations, but also among countries like Japan and Germany are calling themselves UHC champions or health systems champions. There are also many leaders from low and middle income countries who have committed to UHC. And well, the GPW 13 is also, after all, calling for 1 billion more people enjoying benefits from UHC until 2023. So what we argue now is that an economic policy case needs to follow this political case. And this is also not really new to us. Let's think of what UHC means in many countries. It means the expansion of health coverage. And it would be naive to think that that has not a profound effect on choices of people in these countries, consumption choices as well. If you know that you can go to the doctor and can get treatment without suffering catastrophic health payments or just health payments for out of pocket, then you will change your consumption behavior. So that is an aspect that we need to understand a bit more. And that was one thought that we started with. But also, let's stick with the example of the expansion of coverage, and let's leave it that broad for a second. It also implies something for supply chains. It also means something for training of people. We'll come to that in a second. And it also involves other sectors. Let's not imagine that the public sector will do all this. I mean, we can go through many countries and see that the private sector is delivering most of the services. Like in Nigeria or India, we have 7 out of 10 outpatient treatments or visits that are delivered by the private sector. So we have to think that as well. So, and I need to distinguish here our work from what has done before. So that health or public health people, global health people think about the economy is nothing new. So what has changed in our opinion is if you think of Jeffrey Sachs' report, 2001, where we still have an idea of philanthropists will save the world. So this is now my personal opinion. Then moving on to the 2013 Lancet Commission, where investing in health was the new paradigm. And they quantified back then that 24% of the total income growth in low and middle income countries from 2000 to 2011 was actually because of improved healthy lives. So that kind of perspective is already there, a broad macro perspective. But this idea, and I'm researching also at the German Economic Research Institute in Berlin, these kind of arguments, we believe, are not really the arguments you need when you speak to finance ministers and when you speak to people who are used to economic policy arguments and think of their fiscal priorities. So what we argue for is a broader concept. And I'm just sketching. Jeff, you give me a sign if I talk too much. So we started with an analysis that is, to my knowledge, only done so far in Germany. It's called a health satellite account, and it's starting from the national account statistics and trying to identify the elements of where health is contributing to the economic output. So we focus very limited on economic output here, which definitely should be noted as a limitation in all this, because who knows whether more economic output from a health sector comes with more health or healthier people. So we should keep that in mind, but it should not stop us from going into that analysis. So, and what this analysis of this satellite account shows is that we have not just the core health sector, that is like reimbursable in and outpatient visits, but also over-the-counter drugs, but that there is an extended health sector that we should put into our notion of a health industry or a health economy. And that is related to elderly care, that's related to activities surrounding health. You can even include sports, which is not part of this analysis, but you could think of that. So if you take this core sector that we associate usually just with health industry and the extended health sector, what you will find out is that around 12% of the German global gross value added is coming from this health industry. So just to compare the numbers, it's an economic output the size of Austria's economic output. And then if you go to consumption, in this country, every fifth euro that was spent between 2005 and 2012 was actually in the health sector. So out of 100 euros in Germany, 20 were spent on health stuff. So just put that into context. Which industry is providing that? And if that industry doesn't work, what does that mean for this country? So we started off, sorry, I need to get back here. We started off with this, what is this, a notion of services and products. What is actually exchange between people and between firms and people, between doctors and patients? We went one step back and asked ourselves, so what are the resources? And here, because it would be a bit too dry, I'm just noting 3 key resources that we believe we need to speak about in a structured way. So health workforce, and we will hear a lot. I don't need to say anything on that right now. Then it's also capital investment, a completely neglected topic in the global health community, in my opinion. So in the OECD countries, around 0.5% of the GDP was spent in capital investments. And don't get me wrong, capital investment here is real equipment. It's not investment in people, right? So if you buy equipment to teach people, fair enough, that's going there, but not the service. And that should be looked at. Should that be higher? It's much lower than in other sectors, due to its nature in part, but maybe because we are missing out on something here. And then the third part is technology, and I think we will get some examples here as well. So let me, maybe 2 minutes, speak about the effects, because that is a very interesting aspect.
The short 2 minutes.
Short 2 minutes. So just think of the health economy with 3 effects. So, and these are all interesting for finance ministers. I spoke about the economic output, the size of the health sector, but then does it stabilize economic growth? Let's ask us this. So which sectors go down under when there is an economic crisis? Is it the health sector? And then the third one is, and that is super crucial for policymakers, national policymakers, it's driving and stabilizing employment growth. So that is very interesting. If there is a recession, where does the unemployment hit hardest? It's not the health sector. What does that mean for the overall economy? does it stabilize our societies in times of crisis? Thank you.
Thanks, Christian. Now, that gets us off to a good start because this notion of a health economy shows us that, one, it generates capital resources that can be used in two ways. They provide for taxes that eventually become part of the resource that governments use to invest in the public health system. So that's one implication of your analysis. The other is that those resources also are generating products and services themselves that are used in health. And as you said, in Germany, the health economy is greater than the public health sector itself. So that begins to show us that this notion of a health economy actually helps us to understand how more resources can be brought to bear for healthcare. Now, one of the most important parts of that analysis, as you said, is the health workforce, which is a large fraction of the health economy. And it's a growing share of the workforce in many countries, as Jim will tell us more in a moment. But Jim, to turn to you, the question is, health employment is often looked at as a cost. You know, I mean, we can all think of policy papers and health reports in which people bemoan the rising cost that's being invested in personnel in the healthcare system. But I think what's interesting about the work you've been doing is that if you look at health employment as an investment, that leads to some interesting conclusions. So why don't you tell us about that?
Thank you, Jeff, and good afternoon, ladies and gentlemen. I can see many people with their badges, their passes into the assembly. I hope you enjoyed the walk in the sunshine down to here. Jeff and I have been talking about this for about 12 years. Jeff used to be on the board of the Global Health Workforce Alliance. And the narrative back in 2004, 2005, 2006, leading into the World Health Report, was that the world was in crisis. There were not enough health workers to be able to provide the essential services for women, newborns, children that were part of the Millennium Development Goals, that from 2000 through to 2015. And as early as 2004, 2005, we have a whole set of discussions around countries being off track and a crisis in the workforce. And indeed, this narrative of it being an inefficient, ineffective workforce, often absent, often in dual practice, not actually valuing the money, especially when you were talking to ministries of finance, treasury, and the philanthropic saviors of the MDG era, which didn't quite materialize. That has been a long-standing economic perspective, which goes all the way back for the economic students in the room to sort of 1967 and the Baumol effect. So we've had generation after generation of people with an economics degree, an economics major, going into finance and budget positions with a clear perspective that the health workforce was a cost. And a cost to be contained, a cost to ideally be cut with structural adjustment, with imposed external austerity measures. Accordingly, we've seen that in Portugal, Ireland, Greece, and Spain recently. Africa, Latin America, Asia have been having that imposed upon them for more than 40 years. When it comes to Europe, people start looking at it. Nonetheless, we started to look and started to question this. There was some work done learning from the Germany model, which really started to question that, because actually the contribution to the broader economy, and in Germany in particular, where 1 in 6 jobs were in the health economy. Some of that early work that was done by Professor Christopher Pissaridis, a Nobel Prize economist, identified what he called the white economy in terms of the growth in healthcare, and started to unpack this. When I arrived at the World Health Organization a couple of years ago, and we were invited by the member states to develop a global strategy on the health workforce, we took the opportunity, therefore, to really build from the economic literature, from the labor and employment literature. The SDGs allowed us that opportunity. There's a much more coherent economics discussion coming across multiple SDGs and looked at the evidence for that and formed what was called the High-Level Commission on Health, Employment and Economic Growth. And the evidence is overwhelming, it's robust, and it's startling. We recognize that we are one of the fastest growing employment sectors in the world. In the European Union, in the OECD, in high-income countries. The economic demand within our various national boundaries jurisdictions is fueling this demand for qualified health and social care workers. It's also fueling demand for services in aging. So one of the fastest growing employment sectors, which makes these broader contributions to the health economy, to the domestic economy. Part of that growth is also fueled in the private sector. This is not purely a public sector provided either in education services or in service delivery. Part of that economic demand coming from different mechanisms around provision and purchasing of care, maybe publicly funded through a social health insurance system, but privately provided through different mechanisms and commissioning and engagement. The other economic argument that we identified in the data, and is probably the most cited statistic from the work of the High-Level Commission, that 70% of our workforce around the world, where in a sample of over 120 countries, 70% of the workforce is women. We are the average in all other employment sectors being 41%. So we are predominantly offering our economic opportunity, economic participation, tackling SDG 5 around women in the workforce. That said, we recognize there are problems that in the formal labor conditions and the informal labor conditions, and I won't go into the details there, but we presented it to the G20 just last week, the gender pay gap in the health economy. And whilst we have such a strong majority percentage of women, the gender pay gap by profession, by occupation, disaggregated by sex, disaggregated by age, women are still not getting equal pay for equal work in the public and the private sectors, so it's not unique to one or the other. But I think the evidence is overwhelming. 6 economic pathways were identified in terms of investing in the education, employment, retention, and lifelong learning, and the social protection of the health and social care workforce, generates economic growth across 6 different pathways. It promotes social cohesion, it promotes global health security, it promotes good health, many of these other elements. But that said, we still need to have some good governance and stewardship. It's not just to invest in more, it's not just to invest in the same, it's investing in a workforce that's very relevant to the population needs and demands. And we have the universal health coverage ambition, we have the ambitions of healthy lives in the GPW as well. So it's making sure that the skills and the competencies, the enabling environment are there, and a good governance element to come across it. I think what we've got as a result of the High-Level Commission and the global strategy work and the debate over the last couple of years, like I said, is a compelling evidence. What we need now to do is translate that in to the next stage of investment. Germany, clearly in the European context, have understood this for 10, 15, 20 years. Their health economy being one of the most dynamic, the fastest growing, research and development, health and life sciences. And we look, it's not just the clinical health workforce or the support workforce, but the health employment in the economy as a whole. And we need to try and get some of those messages into Treasury, into finance, and into some of our private sector investors as well to look at it. But with the sort of key message from that therefore is around good investment, strong investment with good governance and stewardship. And I see one of my colleagues in the room who's been doing some work on what would good governance be to enable a stronger public-private mix accordingly. One of the, just as a first point here, one of our experts that contributed to bringing all this evidence together, presenting it to the High-Level Commission, was Professor Srinath Reddy, who's also one of the contributors to the book and the evidence here. And from his work in India on universal health coverage and from the Public Health Foundation of India, he put forward the concept of, in this new health economy discussion, in the new SDG discussion, we should be really looking at partnerships for public purpose to replace what is the old PPP, public-private partnership. And that if we can put that public purpose at the center, we value the contribution of both public and private sector investment, public and private sector education, public and private sector service provision under a good governance structure. Back to you, Jeff.
Well, thanks, Jim. That was a really succinct explication of a very complex set of issues, but I really appreciate the clarity that you brought to it. Two issues that I think we can come back to in the discussion later on are the way in which there are opportunities now for private sector investment in this new health economy. And that's something that Christian alluded to, so let's come back to that. And also the question of governance. How do governments exercise their stewardship function over a mixed health system that has both public and private players and public and private investments? And what are the best methods of governance for that? And I know that that Ilona has some views on that. I want to just welcome Ilona Kikbush, who has joined us. Ilona, what I announced earlier, which you didn't hear, is that I'll ask you to make some closing remarks and also to join the panel in just a few minutes. So we'll get to that. But the 2 points that Jim made that I wanted to use to set up Felicia's comments are that first of all, it was interesting to hear you say that from the studies that you did in the commission that 70% of the health workforce in 120 countries are women. And that's, while I don't think that's surprising to anyone, maybe the degree to which the workforce is disproportionately women is surprising. That's one of the ways in which women are both, as we know, are both targets of health interventions because they get ill and they also are caregivers for families and others who get ill. But they're also providers of health care, and that's an important point, I think. And at the same time, you also alluded to the gender pay gap, so some of the gender inequalities in health are also just a fact of life. Now, the work that Felicia's been doing together with colleagues is to really explore even further this relationship between women and health, and what implications does that have for really thinking about ways to improve health outcomes and also to improve opportunities for women. And you've also been looking at the way in which the private sector can have a catalytic role in implementing and promoting the health and empowerment of women through a project called Healthy Women, Healthy Economies. So please tell us some more about how you look at these issues.
Thank you, Jeff. Thank you, Ilona, for hosting us here and for all of your work on this book, which I know any book is a labor of love. This has clearly been one of them, and we're pleased and grateful to being able to participate in the book, and we look forward to this and many other opportunities to share. So, as Jeff alluded to, I want to share first the framework in which we've been thinking about the interactions between women and health. And this comes from a Lancet Commission report that was published in 2005 with my colleagues Anna Langer and Afaf Milius and others. It actually dates a little bit further back to very original work by Julio Frank in Mexico. And it's exactly what Jeff suggested. It's the idea that we want to look at all the different ways that women interact with the health sector. And they certainly interact as consumers, but they also interact as producers. And they produce both as paid participants in the health labor force, but also as unpaid producers of healthcare. Now, this is key to many of the SDGs, those in health, all of those related to gender, and those that relate to economic growth and well-being. It's also key to economic growth for many of the reasons that we've discussed, but thinking specifically about the issue of gender and women, because we know that female labor force participation is a motor of economic growth. And usually what I say is I apologize to the men in the room, but basically your labor force participation rates are flatlined, and they have been for a long time. If you think about what's really changing and dynamic in our world, it's the roller coaster that women have been on for the last 3 or 4 decades around the world, increasing labor force participation, increasing levels of education, increasing opportunities to be able to work. That's what's really dynamic. And we know that 1/2 billion people, women, entered the labor force since 1980, but that they're 40% of the global workforce today, and that the labor force participation rate on average of women is still about 60%. So that's well below where we are for men. It's going like this, it's changing. And finally, this way of thinking about the interactions between women and health is also very key to the idea of a new health economy. And of course, to achieving universal health coverage, particularly in the face of the growing NCD challenge. As I said, the majority of paid producers of healthcare are women, but also the majority of unpaid producers of healthcare of women. So this means that, what I say it in Spanish because it's particularly meaning la neta, like the bottom line, for those of you who speak Spanish, the bottom line is that women produce the majority of health and healthcare around the world, paid and unpaid, and it's largely undervalued, unrecognized, and unsupported or ignored by policy. It's huge, our calculations in the Lancet, and very conservative calculations are 5% of global GDP, and that's tremendously underestimating all the unpaid contributions to the prevention of disease and the promotion of health. When you add that in, I think we're clearly talking about something like double. But on that 5%, just the minimum, about half of that is unpaid and half of that is paid work. The unpaid is therefore a very important hidden subsidy to economies. It also means that when we talk about the size of a health sector, and we talk about 20%, it's actually much larger because there's a part of that health sector that we're not measuring for 2 reasons. One, because it's unpaid and unrecognized, and the other because it's undervalued. So it makes it even larger than we're thinking about in the numbers that we were seeing. Second, it's growing. Okay? The unpaid side is growing because the demand is increasing associated with aging and non-communicable diseases. Right? And second, we need to think about that growth because it's really somewhat at odds with what we're trying to achieve on the labor market side, which is the increased participation and freedom to participate in equal circumstances with men in the paid labor force. On the paid healthcare side, there's also a reason to think carefully about what increases mean. And that's because if you look at not what's happened in nursing or health promotion, but let's talk about doctors. So historically, we would have thought about being a physician as being the epitome of a male profession, right? And actually also, because it was a male profession at the time, very highly regarded. Today, more than 50% of medical students in most countries around the world are women. Now, one thing we have to worry about, we know historically from very good work, people like Claudia Golden from Harvard University have shown that when an occupation becomes feminized, status and wages tend to go down, which is exactly what we don't want to see happening here. But we are seeing that this traditionally male occupation and highly valued occupation is becoming feminized, and we need to think very carefully about how to make sure that that doesn't mean lower wages and less investment. And going back to this, because that would actually mean less investment in women. And we're all talking about investing in women. So underpaying physicians is exactly what we don't want to do. Another set of issues here is around exactly the economic gender gap. So overall, we know that women are underpaid, and the data that we have is that if we think about a status quo, it's going to take 217 years, the way that we're going, to get some kind of equity and equality in labor force participation overall. And one estimate that we have from McKinsey is that if we were to accelerate that process of achieving parity and equity, by 2025, we would add $28 trillion to global economies. That's overall, not necessarily in health. But now let's go back again to look at paid health care, medicine, and doctors. Right? So if we're thinking about the fear of occupational segregation and labor market withdrawal, which is what we are worried about anywhere in labor force participation in women, we have to be particularly concerned about this in medicine. And that's because this is an area of work where there are huge obstacles and barriers. The whole education process tends to be very unfriendly to families and unfriendly to women. Right? You have to do 24-hour shifts when you're in residency, sometimes 36-hour shift in residency. That happens in almost no other area of the labor market. So it's highly unfriendly to the idea of a work-life balance. If we think on the leadership side in healthcare, we also have to be concerned, and just to throw out one data, or two pieces of data actually. One is look at Nobel Prizes in health sciences. Right? How few women have won those prizes, despite our increasing participation in health and healthcare. If you look around the world at how many health ministers have been women, it's only about a third. And that's only because of recent increases. When we try to adjust for this kind of discrimination, we see that women's participation in health and healthcare is actually valued at many times that of men. So it's not just that we produce the majority, it's that the value of what we produce, if we calculate it right, is like 3 times what men are contributing and producing. Now, the good news in all of this is an area that is really rich in policy options, in gender transformative policy options, both for paid and unpaid participation. And that's what I think we'll talk about more in relationship to the private sector. But when we think about a map of policy change, you can think about public, private, and not-for-profit. You have to think about health policies, but also other sector, social sector, daycare, labor market participation, education. These are non-health sectors that influence how women can and do interact with the production of healthcare. And then finally, to think national, subnational, but also local. We will often see gender transformative policy making at all different levels, particularly of the public sector, and how do we account for that? What we're trying to achieve is incentives and equal opportunities for men and women to do 2 things. To be able to participate in labor markets and to be able to enjoy the opportunity to participate in family life. And that requires a series of incentives around unpaid labor force participation, which is key to health, family leave for children, for sick, and for the elderly, training and enabling technologies for caregivers, and even to think really very out of the box, which is compensation and leave. And on the paid side, flexible schedules, equal compensation, mentoring, and leadership. The private sector has a lot to gain from more equitable participation of women in the healthcare sector, but it also has a huge role to play. Now, I'll ask you for me to say a little bit about healthy women, healthy economies now or later. Go into that? Okay. So, and here I'm thrilled to be able to be collaborating with Merck Germany, and particularly with their CEO, Belén Garijo, in thinking through healthy women, healthy economies as a global strategy. It happened to coincide with our work for the Lancet Commission on women in health. And really these 2 ways of thinking, these 2 projects, had a lot of overlap and complementarity, which is what we saw around the publication date of 2015. So one of the things that Healthy Women, Healthy Economies has done is to produce a very interesting policy toolkit that came out in 2015, which is useful both for the private sector but also for the public sector. And I think what's most interesting about that toolkit, which is available online, Chris can tell us more about that, is that it can potentially provide us with a framework for evaluating progress. at all of those different levels, public, private, but also local, subnational, and national. And it's exactly that kind of accountability towards progress that we're pushing in many areas of health and the social sector. There are some specific areas of work around this project, one on embracing carers that is working with 7 leading caregiving global NGOs around the world, another with March of Dimes to transform the way that private sector entities can help to have friendly work environments. I think, from my point of view, the most interesting aspect of this is to ask why and how a company like Merck, Germany, chose to invest and think in this space of healthy women, healthy economies. Now, it is in part because there's a female CEO. Right? And we know how important that is to have women in decision-making places, and not just one woman, but a group of women in order to enable change. I think I'll stop there, leaving a little bit for later discussion, and thank you again for the opportunity.
Thank you, Felicia. Well, that really gives us a much more in-depth picture of one element of what Jim was talking about. And I thought it was fascinating to hear just how much economic activity women generate in the healthcare sector. That's an important figure to keep in mind, that it's an estimated 5% of global GDP, without accounting for the unpaid work that, as you said, is unrecognized and obviously undervalued. And then at the end, as you brought that back to the policy environment, where Healthy Women, Healthy Economy provides a toolkit for helping policymakers to really address these questions in a much more systematic and practical way, so that they can take the perspectives of your research into account in actually changing the way that they approach these issues and take advantage of the dynamism of women in the health workforce to really have an impact. Now, we've taken, as if you've been following the conversation, we've gone from some of the most general perspectives on the health economy to take a progressively more focused look at some aspects of it. And now I wanted to turn to our last speaker, Cicely Thomas, and ask her to reflect on, look at this now through the private sector lens. And achieving universal health coverage is going to require strong public capacities. And part of that will be to steward mixed health systems in which you're taking advantage of both public and private sector resources and capabilities to deliver the health services that people require for UHC. But that is going to be complicated because, as we said earlier, not every country is going to be different. Every country has a complex array of specific political, organizational, economic, and legal factors involved in generating the solutions that are needed. And so what we want to understand is how to manage that complexity. And Cicely and her colleagues, Nathan Blanchett and Adil Ishtiaq, have provided a framework for mapping that complex set of factors to help understand the opportunities and the challenges for more engagement of the private sector in developing systems that will be able to provide universal health coverage. So Cicely, tell us about that.
Thanks very much, Jeff, and thanks to all of you for your interest in this topic, and to my fellow panelists here. So I'm happy to be here to speak a little bit to the experiences that my colleagues and I have had over the last 10 years working in many lower and middle income countries on this issue, on work towards universal health coverage, and thinking specifically about these mixed health systems. And so we know that there's strong theoretical rationale for public-private engagement in terms of how to achieve universal health coverage. We see in many countries that they're struggling to achieve universal health coverage with public provision alone, and that there's really this need to engage the private sector to increase access to health services. And we also see that the health economy is growing, and that will increase country economic development. And we see that consumers are already taking advantage of this private health sector. We see 50% of patients in Malaysia are they're voting with their feet, and they're choosing to go to the private sector to access primary health care. So I think the need that we see at this time that my colleague Jim here has mentioned is really this public stewardship of private sector engagement. And the work and the opportunity I think that we have is to shape and to steward the private sector so that it grows and works towards universal health coverage. As Jeff mentioned, when we actually go about doing this in practice, navigating that engagement is very complex. And often we see this complexity shape itself around several different factors. And this framework that my colleagues and I suggest really focuses on political, organizational, economic, and legal factors. And let me give you just a flavor of what some of that really means in practice at the country level. So when we think about political factors, or political barriers that might impede this public stewardship and engagement with private sector, we see things like ideological barriers, where the public sector may be very comfortable purchasing services or engaging with providers who are not-for-profit, but they might not be as comfortable with engaging for-profit providers. And we see this in Tanzania, Uganda, Ghana, many countries. Organizationally, we also see barriers. So oftentimes, and in most countries, the private sector is very fragmented. We're talking about often many small-scale private providers spread around a country, and there's no availability of kind of an aggregating body in these countries to speak to the public sector. And so public sector suffers from knowing where these private providers are and how to actually engage with them. And of course, we also have these economic barriers. And specifically, we see barriers to public sector capacity and processes for actually successfully engaging with private sector. And that's things like outreach to the private sector. It's things like identifying the private sector. How do you map the private sector? Where are they? What services do they actually provide? Can they provide a comprehensive set of primary healthcare services or whatever services you have decided to put in your benefit packages? And then how do I, as a government employee, how do I negotiate contracts with these private providers? And how do I, importantly, monitor their performance? Are they actually performing to the standard? Are they providing comprehensive care that I'm looking to provide? And we also see these kind of barriers in provider payment and incentives. So when we're looking for how to determine a payment mechanism for both public and private sector, thinking about the variability that we're going to need to have for both of those different sectors. So if we're thinking about doing a capitated rate, we're probably going to need to have a higher capitated rate for private providers because they incur other costs. They do not have public sector workforce provision provided to them. So there are these complexities, these barriers that exist. There are also legal and regulatory barriers. So thinking about credentialing and accreditation for reimbursement. So for small-scale providers in many countries, they may not know what the regulations are. They also may not have the resources to be able to meet those standards or those expectations to engage in that public financing. So I think just to lay that foundation that we see these barriers and we recognize that it's a complex, dynamic system, but I don't think we should stop there. And in the chapter of our book, we do lay out these problems, but I'm reminded of a colleague who shared an African proverb with me that says, if you wish to move mountains tomorrow, you must start by lifting stones today. And I think that some of the work that we've been engaged in over the past few years is to start lifting some of those stones. So thinking about how to do this in a complex system, knowing that there are a complex set of barriers, but being parsimonious about how we choose to begin this discussion. So a couple of recent pieces of work by several colleagues, some from the Joint Learning Network for Universal Health Coverage. So this is a network of country practitioners from around the world, was predominantly lower and middle income countries, is now also inclusive of higher income countries, have come together to think about how do we actually engage with the private sector practically. So we know there's some international guidance that this could be a good idea, but how do we do this in practice on the ground? And so practitioners have come together and tried to map out what that looks like in their countries. And there's a guide that's been developed talking about how to engage the private sector, and specifically in primary healthcare to achieve universal health coverage. And it's titled From Implementers to Implementers. So this is really the nuts and bolts at the country level of how to go about doing this. And the group has started by developing several modules, one on initial communications and engagement for public sector to engage with private sector, and a second one on provider mapping. So as I mentioned, how can you engage with the private sector if you don't know who the private sector is? So you need to figure out who they are, where they are, and what services they may be providing. And I think of a specific case, for instance, from Ghana, where the National Health Insurance Authority there was looking to provide a particular set of services as part of a capitated package, and really realized that they needed to see whether those services could even be provided by a single provider or facility, or whether that needed to be a network of providers. And so they conducted a provider mapping that identified not only where private providers were located geographically, but also what capacity they had to provide those services. And this kind of analysis was incredibly important in terms of making those policy decisions for how these kinds of services would be provided, because what they found is that almost nowhere in the country was one single facility able to provide all of the services that were defined as part of this capitated package. And so what they're proposing, and there is a pilot underway now, is thinking about how to develop a network of providers that could receive a capitated payment to provide that package of services. And so these are just some of the very specific examples of when we go to do this at the country level, what we find. And we also have an example from the private sector side of things, where some social franchise partners have come together to develop a guide for private sector to engage with public sector. So thinking about this from the other side of the coin, we know that the economy is moving towards domestic resource mobilization and away from this donor-funded projects, as we were talking about earlier. And with this transition, many social franchises, many private sector providers, for-profit and not-for-profit, are looking for sources of financing that are sustainable. And one of those is engaging in public financing mechanisms. So we have these examples from countries where they're at least trying to find a entry point to this broader discussion, where we know there are so many barriers, but we need to start somewhere. So let me stop there.
Good. Well, thanks so much, Cicely. That gives us some good insights into the practical ways in which countries are going to have to start thinking about putting together mechanisms for understanding how to engage the private sector in delivering the healthcare services that are going to be required for universal health coverage. And also, you alluded to issues like negotiation of contracts and performance monitoring and evaluation. These are all mechanisms that will have to be developed more. So I think your work will really begin to give us some better insights into how to put the broad perspectives of the health economy into place in specific instances in specific countries. Well, now we've gotten to the point where I think we'll open it up to the audience, because we have about half an hour left. And I'd like to give you a chance to comment and ask questions. Now, if I could ask Ilona to take this seat, and you can join the discussion. And I'll take a few questions from the audience to start us off, and then turn back to the panel. So who would like to start?
There was also a short input from WHO.
We'll do that at the end, yes. Anyone? Well, while you're all thinking, okay, please, go ahead. Yeah. Please identify yourself.
Yeah, thank you very much. Riyad Bazia, independent consultant based in Geneva. I want to ask a question about globalization, but let me share, first of all, about philanthropic institutions. Any philanthropic they can invest any sector where they want or they wish. They can invest in art, but maybe because their own motivations, because maybe his daughter or maybe her husband is dead by cancer, then they dedicate foundation dedicated on medical research. But don't forget that Swiss legal system is the best in the world, that any philanthropic institutions is registered in Switzerland. It's a good idea, yes. But about informal economy, we don't talk any or international organization. It's not really, but in ILO, it is serious informal economy, and there is international legal treaty on domestic workers. So the informal economy, it is reality. But ILO mandate is not public health mandate, which is a mandate of WHO. But ILO, they have program, very interesting, on health safety. But my question about nowadays, yes, the informal economy, health economy, but the challenges of globalization, how we can really make it equal globalization for public health, for equal economy. Thank you.
Okay, well, thanks. So that's a big question. We'll let the panelists think about that for a moment. Yes, please go ahead.
Hi, my name is Jenny. I work for Stop AIDS, an NGO based in London. You talked a little bit about governance in your thoughts, Jim, and I wondered if you could expand to talk about the vulnerabilities of governments with limited resources engaging with the private sector and how we can protect against exploitation. The figures around women in the workforce and the gender pay gap obviously illustrate the fact that even in that microcosm, there's serious exploitation being undertaken through unpaid and through paid care work. So I wondered if you could speak about how we can guard and protect when governments are entering into relationships with the private sector.
Okay, and one more? Yes, right here in the... Oh, well, you're right there, so we'll come back down the list. Go ahead.
Thanks. I'm Peter Varnum from the World Economic Forum. This question is for Cicely and Jim in particular. We're focused on primary care. I think, Cicely, you just met with one of my colleagues recently, and using the forum's platform for public and private cooperation and civil society actors as well. I'm curious a little bit more about your experiences on the country level, and in particular the sort of government-to-government relations when you're talking about a national health plan as well as implementation that's taking place at the county level in some places. Some good practices around that and just general experiences would be helpful. Thanks.
Okay, thanks. So we have three questions, a broad one on the impact of globalization on these issues and how do the perspectives that you've presented relate to that, the question about governance, and then primary care. So, Jim, would you like to start? So a couple of those were...
Couple of those. Firstly, just on the ILO, WHO, when we put forward the high-level commission, ILO was a partner at the head of agency level. We are actively working with them, bringing on board all their social protection mechanisms and all their knowledge around labor, formal, informal. The other thing I'm pleased to announce, WHO this year announced Public Services International as the first ever union in official relations with WHO. We are making sure that our labor and our decent work element is in there and coherent on all of it. On the vulnerabilities in governance, it almost talks to the same point. Making sure that the promotion of health and the promotion of health targets does not erode what should be minimum norms and standards around labor, employment, contractual conditions, around occupational health and safety. We've seen the stories this week alone, and Dr. Tedros acknowledged this in the World Health Assembly, the death of a health worker responding to the Ebola outbreak in DRC, the death of a health worker responding to the Nipah outbreak in India, and the attacks and the deaths of health workers every single week due to the protracted emergencies. The vulnerability issues are critical. Now, in response to that, though, the private sector is not a singular. It is a very plural constituency. And we have to recognize that in that, There is black, white, and many, many, many shades of grey within the middle. And there is good practice, but as the ILO will recognize, there are also some dubious practice by some employers. And I think the governance thing, I particularly think at least introducing ILO and WHO into a partnership together around some of the workforce issues will at least allow us to get better evidence and case studies coming forward of what we can do. And again, also some of my colleagues in the room who are looking at exactly this issue, good practice, key principles, what are the types of things that you can highlight, and doing that type of audit, not just the mapping of who and when and where, but the audit of behavior, the audit of standards to be able to inform some of that work. And that tool very much available at country level in terms of the country experience to help drive some of those primary healthcare discussions as well. One thing, if I may, but on the primary healthcare discussion, linking into this point, we've seen the evidence is quite clear. As we push for promotion of primary healthcare, we should not therefore insist, use external financing for health workers, mainly female, mainly youth, that are in vulnerable employment conditions without contracts, without a guaranteed wage, paid for purely by an incentive mechanisms which are disrupting good principles of healthcare provision. Because if you're paid by performance, if you're paid by a bonus, what do you sell? What has got the highest financial benefit to you individually, not what the person, the woman, the man, the youth actually needs. And we really need to ensure our primary healthcare work is not going down that route. Thank you.
Okay, sure. Cicely, why don't you go ahead and respond to the question that's directed to you?
Sure. Thank you. And thank you for mentioning that, Jim. I think this payment for primary health care is a really important topic and one that many countries are struggling with. And many countries are seeing that how do we actually incentivize providers to provide this comprehensive set of services so that we don't just have a pay-for-performance situation where a single service is being provided more than others. And so I might give the example, I know you're familiar maybe with the Kenyan context, but also in Indonesia where we see both national and subnational level working together. So in Indonesia, BPJS Kesehatan implementing the National Health Insurance Scheme, JKN, work with private providers at the subnational level by using a capitated payment it's a variable capitated payment rate. So private providers are provided with a higher capitated rate to account for the other costs that they incur. We're just doing some work, finishing up with the JLN, looking at regulation of private primary health care in these countries. And what Indonesia is seeing that despite these incentives being in place, there's some disincentives as well. And so part of the scheme also requires that once a provider, whether it be public or private, hits a certain cap, the patients are redistributed to another provider. So that means that if I'm a private provider and I'm trying to increase my patient load, there's a cap. I can't go so far. So there's a disincentive for me to really be engaged with that national health insurance scheme. But we do see several of these initiatives being started, and I think Indonesia would say that they're working through a lot of those practical implementation challenges now.
Thanks, Cicely. Christian wanted to comment on the globalization issue, and then we'll go to Felicia.
So broad question. I hope it's fine if I narrow it down a bit. So let's think of the health economy and what globalization could mean. So you have human resources that you need. So all those qualified workforce participants. What does globalization mean? Well, we see it in the global care chains. It can mean something dramatically negative. I mean, let's take the example of Sri Lanka and the Gulf countries. Look at the annual leave of people from Sri Lanka. There, the move might be not only negative. Look at Central Europe. where a lot of qualified people go from East to Western countries, be it Germany, be it Switzerland, be it UK. There, Romanians, Polish workforce is missing. Qualified workforce is missing. So that is one part of globalization, I believe. The other one, let's think of capital investments, how both positive and negative. Negative, let's think of commercial determinants of health. Coca-Cola or some other multinational firm can have a dramatic impact on my consumption patterns in the countries. One aspect, but the positive one. And here, think of India, the only low and middle income country, or lower middle income country that has an export surplus in health-related goods. The only, right? So the other ones never go beyond 500 million. So, but at the same time, China has no export surplus, but they fight infectious diseases much more effectively than India. So globalization, great, we have a great pharma industry in India, but what about the Indians? Where do these goods go? So we can talk about technology as well, but I think you're cutting me.
Okay. No, it's an interesting point, and it just reminds us that, certainly when you look at the pharma sector, for instance, the supply chains for most pharmaceuticals and vaccines are now integrated globally, and so the kind of comment that you were just making about India's export surplus just reminds us that in analyzing the policies and practices that have to be put in place at the national level, you can't avoid thinking about how these supply chains operate around the world, and so that gets into all sorts of related issues around trade as well. But Felicia, you wanted to comment.
So 3 quick points. One is that, I've really stopped using the term formal and informal. But the reason why is that having worked intensively on a health reform in Mexico, in this case for universal health coverage, the idea of a nebulous informal sector and how you cover them for health is very difficult to implement. The key difference when you think about Social Security or national insurance options and universal health coverage is actually whether or not they're salaried or unsalaried workers. Right? And being an unsalaried worker can actually include the kinds of occupations one sometimes thinks of as being almost more formal, like being a lawyer or being a physician in many cases. It's the idea that you are unable to affiliate to any kind of pooled public financing system. Right? So I just really think it's important to think salary versus not. Second, on globalization is, one of the good things about globalization is labor force mobility. And this can actually be very good for women who work in healthcare. Right? That when there are gaps, if you allow populations to move across boundaries in order to satisfy labor market needs, that can actually be a good thing. Just like you want that to happen within a country, you want as much flexibility as you can in terms of labor market mobility to enable people to move to better opportunities and better options. But just a slightly, I think, deeper point on the issue of primary health care. When I talked about that 5%, actually half of that is unpaid work, but that's 100% devoted to health. The part that no one ever counts is how much time women spend in health promotion or disease prevention that's not direct. So the hours that women spent getting wood to be able to boil water. How much of that is health and how much of that is other kinds of things? When you try to keep a floor clean because children play on that floor, is that domestic work or is that health work? We have no real way to count that, each of those hours, and that's how you get from a figure of 5% to 10 or 13% of a country's GDP. But I think the piece to be really careful about there is that we have, in general, an assumption that women will do volunteer work. In all levels, right? Men do philanthropy, and women donate our time. And I mean, I've I had the unusual experience of being the wife of a minister of health, so I know what this means. But at the primary level of care, what it means is that we assume that an army of women who have other things to do also donate their time. The health promotion workforce is only partially a professional paid group. The vast majority are women who have a lot of other things they have to do, paid or unpaid, and they're expected to keep giving their time, which we then don't count.
Thanks. Well, we have time for another round of questions. I think we had one in the right here.
Thank you very much. My name is Anna. I'm a PhD student in bioethics at the medical school here in Geneva. My question would be for either Felicia or Jim, whoever wants to pick it up. We've heard from Christian, from the first panelist, the fact that UHC would kind of be that political, or the commitment at the political level to UHC has been largely achieved, and now that we need to build an economic policy to support that. However, it seems to me that a lot of the discussion today and some other events this week I've attended go back into this rationale of building the business case for UHC, or building the economic case for UHC, or for gender equality and health. And you know, the goal of balanced budgets is not a goal in itself. The goal of economic profit is not a goal in itself. It's UHC, it's gender equality, it's greater health for everyone. So it seems to me like we haven't really achieved that political commitment if talking to finance ministers remains such a big issue. Am I correct? Thank you.
Okay, thanks. That's a very timely and provocative question. And we had another question up here, right there.
Thank you for your presentation. I'm a dual degree MD and PhD student in the United States, and I'm currently interning at the WHO. My question is specifically to Dr. Knoll. You mentioned that women contribute 3 times as much, and I was just wondering if you can expand on in what regard that happens.
Okay, let's take those two. Felicia, do you want to start?
Sure. So first, I don't think we have to assume that there's sort of a war of the worlds between intrinsic goals, which is more health or more gender equality, and instrumental goals. Right? But the other issue is, reality is that all health ministers have to go and talk to finance ministers. And if they can't use the language of finance to be able to do it, they're not going to get the budget they need. And I've seen this happen in Mexico and in other countries around the world, and I think the good news is that these are complementary discussions. I would be really worried if they were not. So if this were not good for the economy, then I would be really concerned about your concern. The fact that they're very symbiotic means that we should take full advantage of the opportunity of having an economic argument as well as the intrinsic argument. I think where this gets much more difficult is when you go in the realm of the sort of work that Paul Farmer does, and I've worked with Paul quite a bit, when you say there is no economic rationale for doing good health work, but we got to do it anyway. Right? But that's right. But that doesn't mean that we don't have all of the other arguments at our disposal. And then where I got the 3 times, so basically what happens is that women may contribute fewer hours, women may contribute more hours, but if they're underpaid, then the value of their contributions are going to look as though they were less than men. So gender discrimination means that even though women work more hours, it seems as though it's not worth as much. If you do the economic analysis, and that's economic analysis actually, if you do the economic analysis to control for equal experience, equal education, and get rid of the occupational segregation, which isn't real, it's a confounding factor, it doesn't speak to the real value of women's time, then you see that those contributions are actually also worth more in monetary terms, as well as being more hours.
Jim, would you like to comment as well?
Just on the point there, I think WHO's 70th birthday this year, Dr. Tedros has made it very clear that the ambition in the constitution of WHO, equal, everyone has the access to health, irrespective of age, religion, sex, is the underpinning principle and purpose of the organization. We now have this 21st century expression of that constitution in the ambition for universal health coverage. That said, though, we're still not seeing the investment in health and social care. We're not seeing the investment in education, the investment in social protection that is going to be required to reach the DNA of WHO and the DNA of the UHC mechanism. So we have to ensure that our arguments and our communication use every available tool. Unfortunately, in the MDG era, when we put up the reality of women and children dying, we did not, over that 15-year period, we did not see an increase in the investments in the education and employment of the health workforce to deliver that care. What we saw were investments into parallel services, contracted services, targets and everything else, and so there is no alternative. We did not build sustainable, resilient healthcare systems responsive to population needs. This is where we need to change that investment logic across into that.
Yeah, I think that point is absolutely critical. That, and a couple of people alluded to this earlier, and we've heard it all through the week, that unless we change business as usual, we're not going to reach these ambitious goals that the world has, and that Tedros has now articulated for WHO, the triple billion goals, for instance. So we're going to have to find better ways to use all the resources that are available, to invest them in appropriate ways to get the kind of outcomes we would like. That also suggests to me a question I'll pose to Ilona and ask you to make some closing remarks, because we're coming to the end of the time. Richard Horton recently observed about the journey that all countries are taking to universal health coverage. As I mentioned earlier, every country is going to have a different route. As Cicely said, there are different economic, organizational, political, cultural factors that are going to affect that. And Horton said, we have to remember, though, that although these countries are all on journeys, universal health coverage is not a destination. He said it's a constant political struggle. So, Ilona, with that in mind, I wonder, since you're a political scientist, I thought that was an appropriate way to pose a question to you, but maybe you could try to bring some of these threads together for us.
Well, I think anything that affects a population and that affects the economy of a country is a political issue. And when the two of them come together, it becomes a particularly hot political issue, because then it can become a question of whether you have invested enough, whether you're respecting the rights of your population. It becomes a question whether you're investing in the right things, or it can become a question, whether you are actually building a system that is built on an uneven distribution of the benefits of that system. And one of the questions around a health economy is to actually say, what are the dimensions of that system? How is it composed? Who contributes to that economy? And that is done in a variety of ways, as we heard here. And of course, those that draw the most economic benefit from such a system will aim to argue that the basic principles of such a system should continue, so that their benefit is maintained. That can be certain industries, that can be certain professions, for example, and the rules that apply for their incomes, etc. And on the other hand, there is the political push for those who feel the system is actually there for them, a people-centered healthcare system. The outcome should be healthier populations. And that's where you get you can get a contradiction when you are discussing the health economy. The fact is that, yes, particularly as economies move from being industrialized economies to service information economies, and as they develop, one sees that this health economy takes up an ever larger part of the gross national product or income, or however you calculate it then. But the question is, as that goes up from 8 to 10 to 12 to 18, as in some countries, does it actually produce health? And, one could cynically rephrase this wonderful statement, health produces wealth. You could rephrase it and says the health economy produces wealth for whom? Is it a wealth that really reflects on the whole country? Is it what some people are starting to call a well-being society? And that should be the goal. And the question is then not the role of the private sector or the role of women in or the role of X in, but is this a system that produces better health and well-being, while recognizing that parts of that system are organized as a private sector, parts are what we do in the family, however we call it, parts are through professional services. And so I think that is therefore, this discussion is so deeply rooted also in this organization of our societies, because I think today we cannot discuss this question, particularly for the poorest countries, if we're discussing it as if they should reproduce the systems that we have. I was intrigued at a lunch on Tuesday. We had a representative from the ITU, and he said, I've listened to Dr. Tedros, and he says so many billion do not have access to universal health coverage. I listened to my Director General at the ITU, and he tells me how many billion do not have access to information technology. And he says, why don't we sit down and bring the two together and create totally new types of health systems, particularly in the developed countries, that actually produce health. And then, the term health economy would also be quite appropriate.
Well, thanks, Ilona. You did just what I asked and brought all of these threads together with an interesting new perspective on how, fundamentally all of the questions that we're debating around universal health coverage, both in this seminar as well as at the World Health Assembly all week, come down to fundamental questions about values, about social cohesion, about what sorts of society do we want to have. And the role of government is to mediate those questions in a way that helps to allocate resources through a political process, as you said, so that we get the best health for as many people as possible. There's still a lot of work to do on that, but we've heard some really interesting perspectives from our panelists on how we can approach those questions through the lens of thinking about the health economy and the role that the private sector is playing in these manifold ways that you heard about to help us achieve universal health coverage. Just before we close, I'd like to turn to Marjolaine Nicot from the UHC 2030 Secretariat, who's going to tell us about an interesting new activity along these lines. So please.
Thank you. Don't worry, it's just a very short announcement. The discussion has highlighted the important role of the private sector in the health economy and, of course, some of the complexity of engagement with private sector. So this shows the importance to have space for dialogue and exchange on good practice somewhere. And we hope that we can provide this very soon. The UHC 2030 has been established as a multi-stakeholder partnership to promote health system strengthening towards UHC, and we focus on advocacy, accountability, and knowledge sharing. So we have the ambition to bring different actors who are key to play a role in driving progress. And last year, we've been able to establish a constituency for civil society organization, which is starting to play an active role. And now we are ready to establish a platform for private sector. So the aim of this platform is to create a private sector constituency, and it will provide a convening platform for private sector actors to exchange and collaborate, to foster dialogue, and also to provide the interface with various other stakeholders. So we will invite all private sector actors working directly on health system strengthening to join the movement towards UHC and hopefully join this constituency. So we will launch a global call of interest for private sector actors interested to join. So we will do that soon, next month, so it's in 2 weeks from now. And we will have a process for registration on our website. So we really look forward to reach this stage. I mean, it seems that it's, everyone talks about private sector engagement, but nobody really knows, at the global level, but, there are different things in different places. But we hope that we can contribute to, create somehow a kind of global public good. And we look forward to work with the Global Health Center, for example, in terms of, being able to use some of the evidence that you are generating to inform the discussions. You have also a kind of community of practice, which could also play an important role. And of course, we also hope that all of you here with an interest to promote private sector engagement will help disseminate the call. So thank you for the opportunity to make this short announcement, and we look forward to future collaboration.
Good. Well, thank you very much. Just for those of you who want to keep an eye out for the expression of interest that Marjolaine talked about, it's uhc2030.org, or... Oh, okay. Oh, there's a card outside, and the Twitter handle is @UHC2030. So thanks very much. And it sounds to me like the platform that you're talking about will be one important way that we can continue the dialogue that we had here today. So thank you for that. All that remains for me is to thank you for your attention and for your questions and comments, and to ask you to join me in thanking our panelists for sparking such interesting conversation.